Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, Assalamu alaikum. I'm thankful for the organizers for giving me this opportunity to talk on a very important subject. Well, I'll start with the topic as regarding the clinical presentation, course, and the complications. So one need to have an index of suspicion that this gentleman or lady may or might have the interstitial lung disease. And that includes the exertional dyspnea, one of the main complaints, persistent, non-productive cough, bilateral, diffuse interstitial infiltrates on X-ray. This happens quite often. We are being referred to us because of the radiological findings on X-ray or even the CT scan. And at times we have been referred because having a defect on PFT, which is suggestive of restrictive disorder. So these are the few index of suspicions. And a good clinician always starts with a good history. The age, if it's more than 50 years, that favors one of the classical prototype disease of IPF. Middle age, 20 to 40 years, the connective tissue ILD already have been emphasized by my previous speaker. Along with this is sarcoidosis, for example. And in the woman, in the fertile age, the LAM, the lymphangioliomyomatosis, one has to consider along with the connective tissue associated interstitial lung disease. In men, obviously, one need to ask questions regarding the occupational exposures, pneumoconiosis, and especially ILD and RA, which is somewhat more common in men in contrast with other connective tissue disorders, which are more common in women. The next important question in history, which is very important, is the duration. Certain ILDs have a predilection. For example, an acute presentation, which starts from days to weeks, they may have with allergy, acute idiopathic interstitial pneumonia, eosinophilic pneumonia might present with that thing, HP, hypersensitivity pneumonitis. But in all of these, one has to exclude the atypical organisms causing the atypical pneumonia, for example. Subacute presentation, that is from the persons presenting with symptoms from the weeks to months. And in that, this may occur in fact in any of the ILD. But having said that, important things are sarcoidosis, drug-induced ILDs, alveolar hemorrhage syndromes at times, and the lupus pneumonitis as well. And now comes the classical presentation, that is chronic, and that starts from months to years of symptoms, and that includes the classical disease, the IPF. And apart from that, the sarcoidosis, PLCH, pneumoconiosis, connective tissue disorders. There's a huge list of disorders. Sometimes the patients have an episodic presentations with waxing and waning course of disease. And in that, ask this in the history, details about these things. And they may suggest eosinophilic pneumonia, HP, for example, COP, cryptogenic organizing pneumonia, vascularitis, pulmonary hemorrhage, for example. In the past history, one has to focus mainly on, is there any history of prior connective tissue disorders? At times, generally connective tissue disorders precede the articular symptoms, precedes the pulmonary manifestations. But in few cases, the pulmonary is the initial presentations and the connective tissue disorders comes later on. But that is not common. Parasitic infections, one has to dig travel history. HIV, then LIP is more common, for example. Acute or chronic kidney disease, the vasculitides, pulmonary renal syndromes all come into picture, connective tissue associated disorders. Liver disease, think of sarcoidosis, think of primary biliary cirrhosis. Facial nerve palsy, always consider operated enlargement, think of the sarcoidosis. The few things we have as a general have a look about the past history is important. Family history of the rare disorders are autosomal dominant like tuberous sclerosis. Recessive is Hammerman-Ski-Puttelach syndrome, for example. They are very rare. Smoking history, very important question one has to ask. And certain disorders of interstitial lung disease like PLCH is associations, DIP, good pastures, respiratory bronchiolitis, and the pulmonary alveoloproteinosis. So these are the disorders related to smoking. Huge list of drugs. So mainly the antineoplastic, chemotherapeutic agents, some antibiotics like nitrofurantoin, not go into the details. But another very important aspect one has to ask in the history for the diagnosis of ILD is the occupational or other exposures. In the occupational, one has to ask for strict chronological order. I beg your pardon, the strict chronological order of all the occupations which that gentleman or lady had, not one occupation. If he had something before, all of them, and then ask them if their symptoms diminish or disappear on leaving the site and reappear on returning. So these questions suggest a temporal relationship, and that is very important in the diagnosis. For example, HP, hypersensitivity pneumonitis. Coming over the symptoms and signs, like dyspnea is very common complaint. There are certain things when there's extensive lung involvement, parenchymal involvement on chest X-ray, but the patient does not have that main dyspnea being referred to us because of the X-ray findings. So think of sarcoidosis, think of silicosis, think of PLCH, HP, leukoid, lymphocyte, etc. So these are the things. Coming over the another very important signs and symptoms of the wheezing. Wheezing is generally uncommon in patients with ILD. But in some disorders of ILD, like chronic eosinophilic pneumonia, Schruck-Strauss, EGPA, and the RB-ILD and sarcoidosis, patient may present with wheezing as well. Chest pain is not a common symptom with persons with ILD. Frank hemoptysis, not common, generally not common, and blood streaks sputum may have. So it's a rare presenting manifestations. A person presents with frank hemoptysis, but certain disorders like diffuse alveolar hemorrhage, LAM, tuberous sclerosis, and the vasculitis may present like this as well. Very important sign, which has got a very diagnostic value, is Velcro crackles on sign. Don't underestimate these small basic things. And Velcro crackles are what we all know as inspiratory dry crackles, predominantly basilar. And then there are the squeaks, the inspiratory squeaks. And this is generally with the bronchocentric pathologies. And this is common in connective tissue associated disorders of ILD. Clubbing, don't forget clubbing, very important. IPF, asbestosis, chronic HP, DIP, long list. And the signs of pulmonary hypertension suggesting the advanced interstitial lung disease. Well, this slide is basically showing some of the intermingling of the pathologic process, like it starts from inflammation and leading to fibrosis, and there's intermingling. This is from the Lancet review, and this is showing the different factors, like having the imbalance of the pro-fibrogenic and against factors, and that can lead to the significant pathology. Regarding the disease course, one of the important disease courses is completely reversible. Second is self-limiting course of ILD. Third, progressive. Fourth, irreversible. And last, obviously, despite everything, progresses and may have fatal consequences. So completely reversible can happen in HP, NSIP, organizing pneumonia. I'm using the abbreviations, I hope, because everybody is generally related to pulmonology. So I'm using those abbreviations. Progressive is IPF and PPF, for example, the new terminology already been introduced, and we'll talk about that as well. So several ways to classify ILD, but based on the course of the disease, I find this more practical. Inflammatory ILDs, another branch is fibrotic ILDs. You have to divide like this. Fibrotic can be IPF fibrotic ILD. Second is non-IPF fibrosing ILD. Then the non-IPF fibrosing ILD can be further like PPF, progressive pulmonary fibrosis. And this is further divided into the PPF at first presentation. And the last is with the despite management. This is from the European, the European gurus of the ILDs recently published in the consensus. So they divide the PPF. The Americans, as already been mentioned, they have a different, I will just share it, the diagnostic criteria, but this is the European way of classifying this thing, all right? Here comes the same, the PPF definition from the ATS guidelines, right? 2022. So that is an ILD of known or unknown and other than IPF. So this is the progressive pulmonary fibrosis. And they have 3 out of these 3, any 2 should be present. The clinical, the worsening of respiratory symptoms, or the physiological evidence of disease progression. And the last is the radiological. So this is the criteria. And this is what we are saying most of the time, our patients have a progressive disease at times. Now, this diagram is showing the burden of the different intermingling of the manifestations of the ILD having the PPF. And you can see here very clearly that the dotted line represents the progressive pulmonary fibrosis here. One can have chronic HP, and the lowest incidence for this 1.5, the maximum is 47 around, then sarcoidosis around 40s, drug-induced again in 5, ILDs like this, okay? So once you have made another very important point is to look for the risk factors. They are divided into general risk factors like UIP. Itself is a risk factor for PPF, for progressive pulmonary fibrosis. Another is BMI. And the last is the oxygen desaturation during the 6-minute walk test. But there are disease-specific parameters as well, which can suggest the progression. And that include, for example, for fibrotic HP, the decline in FVC of more than 10%. For rheumatoid-associated ILD is having the UIP versus the NSIP, bad prognosis as for the UIP. The systemic sclerosis, for example, have the DLCO decline of more than 15%. So there are risk factors one has to look for. Now, this diagram is tridimensional. It's showing you the intermingling of the ILD. Here's the ILD from mild to here, the vertical direction. Then we have an emphysema here from mild to severe. And here is the pulmonary hypertension. All 3 are very, very important in the management as well. And that is a pathophysiological basis. They are not separate. They are intermingled. And see here, for example, take the example of the first category. Moderate, take the blue one, the second one, because more common, the severe ILD with severe PH. So severe ILD is here, so it must be here, somewhere here at the top, and then has severe PH. So it must be here. So here is the blue one here, because this is the severe PH. So here we are showing the intermingling of the different disorders, the same having the emphysema, ILD, and the vascular component. So don't forget the vascular as well. Now, certain disorders like in PPF, they benefit from the immunosuppressive, and their likelihood of they will respond to the immunosuppressive. They include the OP pattern, the NSIP pattern. And this is in contrast to UIP pattern, older age. Myositis ILD, very good response with the immunosuppressive in PPF, in contrast to recurrent infections, younger age, positive. And the absence of clinical or physiological improvement with increased risk of side effects. This is less. Okay. Now, this slide is basically showing the agents which we use very often in antifibrotic, pirfenidone versus the nintedanib. So see the number of tablets, for example, huge number, 3 to 12, and only 2 for this. Easy. Compliance is related to tablets. We had a FDC for ATT as an example, separate versus the fixed dose. So in side effects, nausea, anorexia, weight loss, photosensitivity, elevated liver enzymes. But for nintedanib is basically the elevated liver enzymes. Outdoor occupation lobby preference is with the nintedanib. Anticoagulation therapy, the preference is with pirfenidone. Ischemic heart disease with the pirfenidone. Cost is variable, so that's nothing is preferable but not available here in our part of the world. So it is another thing. So if there is a newly planned or major surgery, then pirfenidone favorable rather than nintedanib. The impact on quality of life is also more with pirfenidone. This slide is telling you when person has got ILD, think of the vascular component and pulmonary hypertension. And pulmonary hypertension, don't always think it will always be group 3. Yes, commonly, yes. Group 3 is with lung disease, but group 1, don't forget that thing. Pre-capillary. It's got recently a lot of data on this thing. So I'm sharing this slide to able to differentiate what is favors what. For example, in this group 1 is normal or mildly impaired. What pulmonary function? But the TLCO is also low. So in generally in the group 1, the PFT is not that bad as far as the pulmonary hypertension is concerned. But in contrast to group 3, the PFT will be very bad as compared. This is the differentiating point between the two. Another is to look for the HRCT. Obviously, they will absent or only modest or mild to moderate changes on the parenchymal on the HRCT. Having said that, you have a characteristic advanced staging on the group 3 associated ILD. So moderate to severe PH pulmonary hypertension for the right heart cath and diagnosed on the transthoracic echo, whereas in the favor with the PH-ILD of group 3 will have mild to moderate one. The risk factors for HIV, connective tissue, and the mutation will be likely to be present in group 1. Well, there will be likely to be absent in group 3. Right. Now, this slide, I'm not sure you will be able to see from it, but I just want to emphasize that some of the trials of the ILD and how they are doing it. And it's difficult for me to read as well from here. So I go more clear. So excuse me for that thing as well. So I mean the phosphodiesterase 5 inhibitors, the STEP IFVF, for example, they are negative results. Apart from the improvement in quality of life and oxygenation, but the results are negative for this. The only thing I have to mention is ambristatin and rosigard, because they are harmful effects. So they should be avoided, these two for this, right? So last couple of slides. So this is the last 2 slides that I'm just concluding my talk with is antigen a potential causative agent present and you have removed it? Yes, you go for the treatment indications like for ANCA associated and all this. Look for the first line therapy available, which is based on evidence specific to disease. For example, sarcoidosis, from systemic sclerosis, go for MMF, go for tocilizumab, cyclophosphamide. If there is an ANCA associated, go for specific therapy like rituximab or cyclophosphamide, followed by the maintenance. That was the induction. LAM is the mTOR inhibitors, and PAP is the whole lung lavage and GM-CSF, for example, specific. So the second last is another question one has to ask is there a chance of reversibility or stability with immunosuppression? If it's yes, then go for this. Has happened usually in sarcoidosis and systemic sclerosis as ILD. The second last question, is there a disease progression? Yes or no? And you have to decide whether fibrotics has to be added or not. So the last slide is complications of respiratory failure, type 1 or type 2. Eventually, all type 1 turns into type 2. Look for the opportunistic infections, including the tuberculosis. Don't forget TB. And pulmonary hypertension has to be considered and treated accordingly. And the last is to look for possibility of lung cancer, I think. Thank you very much.